Welcome to Higher Caliber, where each week we dive into the backstory and history of the people and companies that keep America running.
All right, everybody, I'm here with Mike Center. Mike, why don't you go ahead and introduce yourself, let us know what you do, and just tell us a little story about how you got to that point and everything leading up to it.
Sure. So, hey everybody, my name is Mike. Jared, thanks for having me on today. I really appreciate the opportunity. What I currently do is I'm a chief administrative officer for a large medical group in Columbus, Ohio. In my career as a healthcare executive, I either run large medical groups or smaller hospitals as a administrative type or a CEO or a COO type. Basically, when I got out of high school, I had been away for high school. I was fortunate enough to leave home when I was around 13 and go away to school. And when I came back home, I really didn't know what I wanted to do. One thing that really interested me was being a paramedic, and I decided that might be something good to do. But the catalyst behind that was one day I was at home, my parents' home, and my sister, who's several years older than I am, passed out. And I caught her as she went to the ground. And of course, back then we didn't have 911 like we do today. We had a 7-digit phone number. And so I called that, and I got the local fire department coming. But I remember feeling absolutely helpless. Right? So there's nothing I could do. I didn't know what to do. I could just stand by and watch. And it's at that point that I decided I had to go do something to help people.
Right.
So I enrolled in college, and I decided to become a paramedic. Now, I knew so little about healthcare and about emergency medical services that for any of you listening that are in emergency medical services, whether you're in the fire, EMS, or law enforcement, you probably get a chuckle out of this because they handed me a pamphlet, 2 pamphlets. One said EMTA, all right, and one said EMTP. Well, most people understand today that EMTA back in the day meant Emergency Medical Technician Ambulance, and EMTP means Emergency Medical Technician Paramedic. Well, I thought it meant Emergency Medical Technician Amateur and Emergency Medical Technician Professional. And I had no idea. I really didn't. So I started off in college, and I went through, and after a couple years, I graduated through the program, and I became a paramedic and started working. And I worked as a paramedic, and I rose through the ranks very quickly. And about 4.5, 5 years into my career, I became an assistant chief. And that was a short stay. That was a short run. We lost our chief, and I was promoted to chief pretty soon after that. Well, when you're a young guy and you don't have a lot of leadership experience, it's difficult, and it's difficult to deal with people, and it's difficult to learn those people. So my career went on. As anyone knows, in EMS and fire, the hours can be extremely long. And I remember as a chief one day, I was sitting in my house in a rocking chair, and my oldest son walked up to me and asked me a question. I was actually reading a book, and I looked up from the book to answer his question, and it hit me, you don't know this kid, right? You work so much, you don't know this kid. Now, at that time in my life, I had another little boy, and I had a little girl, and I said to myself, you have to do something different. So my wife found this job in Columbus, and I'd have to drive like an hour and 45 minutes to work.
Well,
one way. So I went and I interviewed for this job, and they liked me for this job because of the fact that at that point they thought I was a leader and that I knew enough about healthcare to do this job. And what I actually did was run a large primary care medical practice, the largest that they had in Columbus at the time. And after 2 years, I was able to make it profitable. Well, to me, that seemed a pretty easy gig because understanding, you've got so many patients and you make so much money and you have so much staff, and what do you really need to make money and to save money? And I was able to do that. From there, the business sold hands, and I went into consulting, and then I went from running one practice to 14. Now, 14 practices kept me all over Columbus, and I burned up a couple cars. But what I found was that was pretty easy. So I did something back in the 90s that was rather taboo. And today it's pretty mainstream, but back then it was pretty taboo. I went to an online college. And most people back then thought that an online college was a fake, right? You didn't have to do anything. And some of the software that was created back then has been perfected today and is used by many universities around the country. So when I finished up my bachelor's degree, I decided to go straight into a master's degree. And I looked at all the different brick and mortar schools, and I looked at the online colleges, and I thought, well, this is really unfair because the online colleges are cheaper, but it takes a lot more work. And what I mean by that, when you're in a master's program, you have to do a thesis. Well, at Ohio State, when I looked at their thesis requirements, it was 25 type pages.
Wow.
In an internet college, an online school, to prove that they were not a sham, I actually had to produce a book that ended up being 145 pages long. And it was published in a hardcover. It was a research paper, but it was a hardcover bound book that the school kept in their library for other students who might want to do research in the area that I had done a lot of research in.
You remember the title?
No. Quite frankly, no. Because it was a stupid title. It was a long title. I was actually doing a thesis comparing medical practices, primary care practices, ones that had adapted to the current clinical and business environment and were successful because they measured their metrics and they changed their operations to be more efficient so that those metrics would move in the right direction. Versus other traditional practices who never changed, who in the increasing business environment lost money. Right?
Okay.
So, and being a consultant, I was able to pull a lot of data from practices that was real-time data that I had access to try to show people that if you do not conform right to these things, you're not going to win.
Right.
Now, unfortunately, healthcare went through many iterations to get where it is today. And a lot of pilots, a lot of tests, mainly coming out of Medicare and Medicaid, on how to reimburse people in the healthcare world for what they do. And I attended a lot of lectures for people much smarter than myself, and some people that thought they were smarter than myself but were really dumb. They really didn't have a clue. And what it came down to, and what healthcare forgot in the transition, was they wanted to incentivize people to keep people healthy. And what they ended up doing was incentivizing people not to see sick people. Right?
Oh, wow.
And so that was really in the late 90s and the early 2000s. And then really Medicare, believe it or not, I know he gets a bad rap all the time. And I personally didn't like his policies. But when you think about people like Barack Obama, who actually directed Medicare to set up a center of innovation. Mm-hmm. And when people were sat into a room and said, you have to be innovative, I don't know if they knew what that meant, but people really had to start thinking about how do we take care of people and how do we properly incentivize people to do that? Well, that actually worked. And some of the programs they came up with someone in the room, I don't know who it was, but someone had the foresight to keep asking the question that a lot of healthcare leaders don't ask today. What about the patient,
Oh yeah.
right? Because people, they think about metrics, they think about dollars, and they think about efficiency, but they don't always think about the patient. I can't tell you how many times I've gone in to interview for a job, and when you're a guy in a career like mine and you've got as much education and fellowships behind you as I do, when I go in for a job interview, it is me interviewing a company. It's not a company interviewing me.
All right.
And when I sit around a room and people talk to me, and I go into a company and they don't want to talk about the patient, right? They want to talk about metrics, and they want to talk about staffing, and they want to talk about supply chain and technology. Well, that company doesn't do a good job taking care of patients. I'm sorry, they don't. Now, they may have good numbers, they may make a lot of money, but their patients really suffer, in my opinion. So when you have a company that really cares about patients, do they make a lot of money? No, they really don't. Do they survive? Yes. But what do they really do? They make a lasting impact on their community, right? So it's not this big giant hospital system making money. It's actually people out there doing things for other people that make an impact on their lives, and not only the patients, but their families as well, and really improves the whole community. So, long story, not short, long story, but that's what happened. I really felt a personal need to get involved. And then as I went through my career, I saw a need that I wasn't utilizing my skills. And there was more passion there that I had to really get involved in. That's what I did. And that's my career.
What do you want to talk about? Like, let's back up a little bit. I know we talked about you using college credits between the Army and the Navy. You want to talk about that a little bit?
Sure. So I was one of the people that when you're in the Guard and the Reserves, you certainly don't make any money at it. But what you do is you build leadership skills. And I spent 6.5 years on the Guard side of the military. Actually, Ohio is one of the 6 states, actually 5 now, that actually has a Navy.
Who got rid of the Navy?
Texas.
Oh.
Texas turned it over to their version of Department of Homeland Security, kind of thing, and the Border Patrol, and because they were doing the bulk of the work. But as I went through, I was using that to build college credits from the War College, the Naval War College, the Army War College. So when I did go back to college, I had a lot of credits built up. They actually, it was kind of funny. It was supposed to be a 2-year program, but because all the credits that I had that actually transferred, put it down to about 14, 15 months for me. So it was actually a good deal. I did a lot of work and a lot of good work, but it actually paid off for me in the end because it lessened the time that I had to go through college. So it was really good.
And you got your EMT and medic card through a college-based program.
I did. I went to college,
and there wasn't a national registry back then.
Well, the national registry, the pamphlets I talked to you about actually came from the national registry, but it was a joke. And in my opinion, in several ways, it still is. But what I was looking at then was, I'm old enough that when I took my paramedic test, it was the first state standardized test in Ohio. And what I mean by that is usually the school would write the test, and a physician would approve it. It would be sent to the state medical board or board of EMS, and they would approve it, and then you would be able to take that particular test. What's different about then and today, looking over the National Registry, the written tests are fairly similar, if I could say that. The practical applications are completely different. And what I mean by practical applications is that today we have things like moulage, where you make a patient look like they have an injury and you kind of coax them on what to say and do. when I had to do my practical exams, there was a board certified ER physician there. There was also several nurses uh, and other proctors that would watch you perform. And what I mean by that is that if they wanted you to see you perform a particular skill, like put the ancient mass pants on, or start an IV, or give an injection, or put a nasal airway in, you had to do that on a live human being, right? So it had to be a classmate, and you had to endure the pain as well. Um, and they would change your scenario constantly. They would do different things for you. We had to test out in medicine, and we also had to test out in trauma. And those evaluations typically took about 30 to 40 minutes per person. And you had a team of people like you do now that you had to direct, but it wasn't so much pretend. You had real needles, you had
Yeah.
real tubes, and there's things that you had to do. And the difference is that back then, in the early 1980s, we were coming out of still the Vietnam phase, right?
Yeah.
And the Vietnam medics,
Really salty
they
bunch.
were, they were, but they were really good at what they did. And a lot of the curriculum in Ohio, because Ohio was one of the first states to really adopt EMS, right? I mean,
Yeah.
California gets the credit, but it really started in Ohio at about 1967. Um, and we trained like Vietnam medics.
Yeah.
You know, our curriculum was that. It wasn't until 1985 where they came out with a national curriculum, because in other states they didn't call people paramedics, right? So in other states like Georgia, when you were the highest level, you were a cardiac technician, right? You weren't a paramedic. In Canada, Canada took a totally and completely different. Canada back then was a 4-year college degree to be a paramedic.
Wow.
You know, in other countries around the world, they look at EMS differently. And the fact that if you go to Russia, right, and on a Russian ambulance is a physician. There are technicians like paramedics, there are nurses, and their goal is to treat you at home. Now, they were doing that back in the late 80s and early 90s. Now, if you compare what Russia was doing in Eastern Europe, and you look at today in the United States, back just before the COVID pandemic, many hospital organizations launched what was called a program. It was called Hospital at Home. And what Hospital at Home did was it helped them reduce hospital lengths of stay. So if you were sick in the hospital and they'd say, well, they need this antibiotic, so this IV infusion, we have to keep them for 3 days. No, we transfer them home.
Wow.
For people that had COVID, in the first round, that it was so bad, and they'd say, well, their oxygen demands are such that we need to keep them on 5 liters all the time, we were able to send them home. And what we did with that is we supported them through telemedicine with physicians. We had nurses on the ground. We had respiratory therapists on the ground. We had pharmacists reviewing their care and delivering new medications. And we had case managers who were working with the family that were actually coordinating special equipment, more oxygen, and things like that. And around the country, that was a major success, and it still goes on today. In many of the bigger institutions, like in New York and California, and even in Colorado, where people are able to recover at home with their family, and they do much better. Studies now are coming out that show that these people recover faster, they recover stronger, and their downtime is actually less. And what I mean by downtime is there's a lot of studies based around how many days a person lays in a hospital bed, right? So you have an elderly person, and I'm saying elderly person, I'm saying mid-70s, they're in a hospital bed, they've got something wrong with them, and we keep them in that bed for 5 days. And then their family calls back 2 weeks later and says, Mom isn't getting up, she's not very strong. Well, it's going to take Mom 5 weeks to recover from those 5 days.
Yeah.
And most people don't get that, because we found that really the average length is about a week for someone to recover for every day we kept them in a bed and we didn't get them up.
Is it the bed then?
It is the bed. And the problem is, again, hospital business model. So many nurses for so many patients, right?
Yeah.
And post-pandemic, what's going on is we have a nursing shortage all over the country, and we can't get people into hospital beds to be cared for appropriately. So they're being held in an emergency department on a bed, and people are checking on them, but they're really not getting the care they need. And what people don't understand by that is that it's not the medications, it's not trips to the bathroom, it's actually getting a patient up and walking them.
Right.
So, their muscles stay strong, getting them the proper nutrition they need, the adequate nutrition to keep them moving and following their case so they get out of the hospital sooner. And right now, we have a very difficult time with that because people just are not getting the care that they really deserve because we don't have the staff to do it.
It's a shame.
It really is. It really is. But that's healthcare in America today.
Yeah.
So, but the Eastern Europeans figured that out a long time ago.
Really?
And we're just getting to it.
Do you think they have better health care than we do?
Well,
I know that's kind of a broad...
It is broad, but I work with physicians that have been trained all over the world. And what I find is that in America, again, it's like a lottery system, right? If you're a doctor and you want to come to America, you have to be the best and brightest your country has, right?
Yeah.
To come over because there's only so many slots. And well, the biggest country I think that brings physicians in, and we all see it and we call it out, it's India, right?
Yeah.
I mean, they have a lot of Indian-based physicians.
Yeah.
But the physicians that I've dealt with from Eastern Europe, whether it be Russia or Ukraine or Armenia, those people are good, right? But the difference is, it's kind of funny in American culture. They care about their patients, and they're very vested in what happens to their patients, but they're very blunt, right? and so in America, we're not used to that. So if a Russian doctor walks in, they will take wonderful care of you, right? But they'll say, you don't need to be here. Now in America, we don't want to hear that. And why don't we want to hear that? Well, because mom's sick, and I'm home, I've got 3 kids, I've got a husband who's busy at work, I'm trying to work, I can't take care of mom. You need to keep mom in the hospital. And that Russian doctor will say, no, no, this is time to go home. It's your family, because their culture is different.
Yeah.
They're culturally based. And the fact that we all love our families, but they believe they have a duty to take care of their family, right? So if mom and dad are sick, then they need to stay at the house. And
Yeah.
you need to find someone to take care of them because that's your job. And people in the United States, if you look to Asia, for example, Japan's hospital system is completely different in the fact that, Japan provides you a doctor and a nurse and a bed. That's it. So the family is supposed to provide you with your bedding and your clothing and your food.
Yeah.
Right? There's no hospital food, right? So you can get it, but Americans that go to outside of a military base, they go to a Japanese hospital, they're shocked. They're like, what are you doing? Well, it's your job.
Yeah.
Well, don't you have nurses? Well, yeah, but you're supposed to take care of them.
Right. You're going to change their bedding and...
You're going to take them to the bathroom, here's their pills, give them one of these. I mean, that's the kind of thing it is. So healthcare around the world is completely different. If you look at what happened during the pandemic, I got to hear about and see on video firsthand, like in India. India was ravaged by COVID. And the shame of it was that everybody was struggling to get basic needs. Oxygen, right? And you think, well, oxygen, yeah, well, we can get oxygen.
Right.
Well, even in America, we were running out of oxygen. And in India, they would pass around a single face mask, and they would line people up outside the hospital, and they would let them breathe oxygen for 15 minutes. Well,
For a respiratory illness.
for a respiratory illness, right? Because they had to pass it around. Well, that's all they could do.
Right.
And it was frustrating. I mean, I talked to some of the physicians that actually worked over there, and their families, and they were in tears.
Yeah.
I mean, they were watching people die every hour, and they couldn't do anything about it. And it got so bad they had to just pile the bodies up and burn them, right?
Wow.
Because they couldn't do anything about it. And and you think about in America, right? And somebody's on home oxygen and they're on 2 or 3 liters. These people were requiring 50 liters of oxygen, and no little tank is going to produce that. And they didn't have that kind of resource. They knew they needed oxygen. They knew what they needed. Physicians were smart. They were reading the same research that was coming out of America and Europe and places like that.
Do you know if they had a high intubation rate like Italy? They just threw everybody on ventilators because they didn't know.
They had no ventilators.
Yeah.
I mean, people don't understand that we're very fortunate in America to have the health care that we do.
Right.
But if you had socialized medicine, I mean, now in the government, I mean, I don't want to get too much into politics, but if you look in the government today and they talk about, well, Medicare for everyone.
Yeah.
No, no, it doesn't work. And the reason socialized medicine doesn't work, and you only have to look to places like Europe that are heavily socialized, and I've had friends in Europe that have told me these horror stories. Right now, if you're 45 years old and you have a sports injury, and the doctor says, well, really you need a knee replacement. Well, that probably doesn't happen in Germany until you're 55, 56 years old.
Right.
So what are you supposed to do? You live in pain.
You just deal with it.
You deal with it, right? And so if you told somebody in America that today, right, that, well, no, that orthopedic specialist, you'll see them next year, okay, and you'll get your MRI just before that, and because we got to pay for that, and you're not paying for it, so we're in control. If you told Americans that today, right, because we've spoiled Americans, because what do we have? We have Medicare and Medicaid.
Right.
And in Medicaid, in my opinion, do they always, people on Medicaid get the best care? No, I don't think that they do. But on the other hand, they get care.
Right.
In the United States, with the healthcare dollar, you will spend, if you look at your whole life, you will spend over 60% or more of all the money spent on you in healthcare from the time you were born in the last 5 years of your life. And the reason is that we know people are going to die, right?
Yeah.
We know people are going to die. They have these horrible cancers. They've got a terrible heart. Their lungs just don't work. Their kidneys don't function. But we've like, hey, we can hold this off for 5 to 7 years. I mean, how freaking long do you need to say goodbye to mom or dad, right? I mean, and it comes down to a point where you love these people and you care about them, but what are you putting them through?
Right.
Now, I look at my own father. My dad drank a lot. He smoked cigars, smoked cigarettes. He worked in a factory. And right after he retired, he got sick. And they diagnosed him with pancreatic cancer. Now, my dad was one of those people who was a good old country boy. He grew up poor in a dirt floor house. And he looked at me and he's like, they want to do all these things to me. Is it going to save me? And I'm like, no, you're going to die.
Right.
And he's like, well, boy, pull this shit out of me. Meaning his IVs and his tubes. And he's like, let's go home and get a beer. And that's exactly what we did. Now, he made it 6 months.
Yeah.
But he didn't want to live like that.
Right.
He didn't want to prolong his life where he was, a person that was just being taken care of by other people and really hampering his family. And he really wanted to be that person that lived his life and can look back, and it's kind of like that old adage, if you go into the grave with a perfect body, you didn't live life, right?
Right.
And that's exactly who he was. And really, when you think about it, death is a scary thing, and most people don't want to face that. And there's probably a lot of reasons for that. I mean, I have my own personal reasons. I'm sitting here, I'm 58 years old, and I'm not afraid of death. If someone told me, hey, you're going to be dead in 5 minutes, I'd be like, oh, okay, I'll be dead in 5 minutes, right? Because I believe there's something more. But there's still a lot of people out there that don't do that because our society has changed. I mean, we could do a whole podcast on how society has changed from 1964, when I was born, until 2022, where we're sitting today, right? Long time. If you think about it, I mean, there are there are people out there and there are cultures where people smoke, people drink. I mean, people drank since the time of Jesus, right? People drank, but it all depends on how you take care of yourself, right?
Right.
And something I think in America that we've gotten away from is we've tried cause and effect. The cause is, I think, in many ways in America today, the basic notion of the family has been destroyed.
Right.
Well, what happened to that? What was the effect of that? Well, we had a single mom. We had two parents that worked. And they didn't have time to take care of the children. So it was easier to take a prepackaged food and pop it in the microwave and set it in front of the kid than it was to cook dinner with real food,
Right.
and put it in front of them and give them a healthy diet, right? And so I see a lot of things today, if you look at wellness programs, getting people's asses off the couch, right? I mean, that's a big thing, right? We have a Fitbit. Fitbit will remind you, hey, you need to walk, right? And people look at it and say, okay, maybe I should have tied this damn thing to my ankle, right? and they don't understand that, no, it's not killing yourself in the gym, right? That's not always the case. But proper nutrition for children and proper giving them time to play, and even as a young adult doing the same thing and keeping your body moving, that's what keeps you healthy, right?
Right.
So nutrition is the key for a lot of this. And a lot of this, we've known this for years, but in Medicare's Center for Innovation, one of the big things that they came out with was a healthy lifestyle, right? I mean, yes, stop smoking. Smoking's bad. Don't drink in excess. You can't tell me I like bourbon, okay? I broke that rule, okay? But the thing is, if you eat well and you're mobile, right, you don't have to run a marathon, right?
Right.
If you keep active, those things keep you healthy versus just sitting around eating prepackaged food and you know, I don't know. I mean, coffee should be black, right? It doesn't need cream from Carnation, right? I mean, that's the way
Well,
it is.
you were a salty paramedic and officer in the Navy, and so
But you just drink black coffee.
you just
right?
drink black coffee.
Right,
Yeah.
right.
All right. Well, we're gonna wrap this up, but before you leave, if you could give yourself advice from when you were younger, what would it be?
So my advice to myself would be to do what makes you happy and find a passion for it. Your money and your life will follow. And I think that's the best advice I could give anybody.
Well, that's great advice. All right, Mike. Well, thanks for coming on. I really appreciate it, and we'll have you on later.
Okay.
All right.
Thank you very much.
Thanks.